Hello, everyone. I'm so excited to join you today. I'm Dr. Lori Spoozak. I'm a gynecologic oncologist and doctor of palliative medicine at the University of Kansas School of Medicine and Cancer Center. Today, I'm really excited to talk to you about thriving with cancer, optimizing ourselves through the cancer care journey. This is the first time that I've actually been engaged in a live session with the OCRA national meeting. Last year, I was able to do a recorded session, which was great, but I'm excited to see how this works when we're engaging folks through the chat. Let me know if I'm missing messages. Hopefully the media team will help, and I'm so excited and grateful to be able to talk to everyone today. We have a woman-to-woman program here at the University of Kansas that we started, I want to say back in 2019 is when we got the grant. And so I'm just so grateful to OCRA for all the work they do in advocacy and research. So here we go. My first, oops, there we go. Okay, my first slide is actually a question to the group. And I'm wondering if we can see how this chat works. What does it mean to everyone to live well? And does cancer change what it means to live well? So I'm going to toss that out to everyone and see if we get some responses. I'm looking through there and I see who's joined. Do we see any responses yet? Live with meaning. Oh, here we go. Living well, being positive. Love it. What else? Quality of life versus quantity. Love it. Seizing the moment. Yes. I love all these answers. If you ask 50 different people, being able to do the activities you love, meaningful things and creating family memories, focusing on what you can control in the face of what you cannot. Ooh, you all are on it. You know, you don't even need this talk. You know what we're going to be talking about already. I'm so excited today. I actually just left my palliative care clinic to come and start this talk, and I actually was sitting with a new patient, and I see all comers with cancer. Some of them are male patients. I know, shocker for this group. But he was talking about how he's seeing his days differently now. He was noticing the change of the trees and the light of the sun. And maybe I'm thinking about, how does cancer change what it means to live well? Maybe we notice being alive in a different way when we have cancer, but still yet living well means probably the same thing before and after a cancer diagnosis. Maybe we just pay more attention to it. But I love, I'm looking at more responses here. Mindfulness becomes so much more important. Cancer changes what it means to live well. Being functional, having quality of life, not just quantity. Do what I love. And then there's the last question. Ooh, what is palliative care? Ooh, I love this question. So we're going to get into all of these things in our talk today. Okay, so what does survivorship look like in 2023? I think is like a really important place to start this conversation about thriving with cancer, okay? It looks a lot different than when I started my training back in the early 2000s. So what does it look like now? It looks like sometimes maintenance therapy, PARP inhibitors, even if your cancer is gone, bevacizumab, even if your cancer is gone, multiple times where cancer goes away and then it recurs and then it goes away again, multiple rounds of chemotherapy or targeted therapy, okay, cell killing or targeted to different molecules. Some people are living on chronic cancer therapy with disease that stays stable. Some people have multiple surgeries. Some people have radiation or other interventions. And so what we know that survivorship looks like now, the story of cancer is not just, I get it, I'm cured, or I die from it. There's this whole world in between that looks way different and is changing in ways that we couldn't have even imagined before. So what I know is that a lot of my patients are carrying around this backpack of symptoms and stresses. Some of those are from the cancer itself, but a lot of them are actually from the treatments that we give to patients. And each time we put in a new treatment, we're throwing in more symptoms and stresses into that backpack. And it looks like more and more of a burden. And so those things impact our quality of life and all of the things that we want as our goals for living well. So I'm just going to throw this question out to the group as well. What are symptoms and how do we assess them? So everyone's been super active in the chat, which I'm so stoked about. This is really working. So tell me, I'm going to just take a beat. Tell me in your words, changes due to treatment, okay? What else, what are symptoms? So anything out of your usual state of health. Neuropathy, yes. What are symptoms for neuropathy? So it sounds like neuropathy is really coming up. Something you didn't have prior to treatment. Fear, fatigue, yes. So basically symptoms out of the normal conditions, chemo brain, fatigue, yes. Things that unfortunately feel not to feel, yeah. Depression, joint pain, all of these, yes, all of these things are symptoms. And so what I like to think about is symptoms are stresses on the body, something that causes suffering, but not just to the body, also it can be to the mind. It can be to our pocketbooks, our bank accounts. Financial toxicity is what a lot of people talk about. To our social world, the stress of cancer can really impact our relationships with family. So symptoms are not just what happens in the body, but it's also what happens in our mind and the entire world around us, right? Our spiritual symptoms. And how do we assess them? Well, I'm going to talk to you a little bit about one tool to look at symptoms, okay? Just so that we're all in the same starting place about this conversation. So this is a tool that we use in our palliative care clinic. Sometimes I also use it in my gynec clinic too. It's called the Edmonton Symptom Assessment Scale, and it's a really simple tool that we use at the start of our visits that we assess pain, tiredness or fatigue, nausea, depression, anxiety, drowsiness, appetite, the sense of well-being, or how am I doing inside myself, shortness of breath. So this tool was created because what we learned through research is that if you ask a person how they're doing, most of the time the answer is, I'm fine. Or they might say one of these symptoms, okay? But a lot of people don't realize that all of these things are symptoms. And actually, another thing that's true is if we don't ask about them directly and ask you to rate how they are subjectively with a scale of 0 to 10, even though it's annoying to do that, I'll be honest, I know nobody likes this. I don't like it at my visits, but unless we do this, most people, and this is found in research, don't report symptoms. And so if we don't report them, then we don't know what we can do to help fix them. The other thing that I know is true is if we ask, we learn that our patients with cancer are carrying around tons of symptoms. This is the one sort of technical slide I'm going to put up for the whole presentation, and I'm going to walk us through it slowly so that hopefully everyone can understand it. This is from a study I did back when I was a resident doctor, and it was in collaboration with this group out of Cancer Care Ontario in Canada when they started using those symptom scales. Pardon. My brain is in palliative care mode, and I'm really worried about how much people poop. Anyway, constipation is one of those symptoms that we really need to deal with in cancer care. So I apologize for misspeaking. Anyway, so this was the first group that started to look prospectively, meaning going forward with each treatment that a patient got, how their symptoms were doing on a true scale, and then also how is their function doing. And they followed patients who had GYN cancer, so ovarian, endometrial, cervix, vaginal, vulvar cancers over time and tracked those symptom scores. What we know is that when people have a score of greater than 4, between 4 and 10 on that symptom scale that I showed you on the last slide, that those are symptoms that need to be treated with some kind of tool, intervention, medicine, some kind of referral to someone, but they're significant symptoms. And so in this study, we basically mapped people in the 6 months before they died. And why is that important? It's not what happens actually over here in the time right up close to death. It's actually what I'm most interested in, 6 months before death, that 50% of that group of patients, and it was like 1,400 patients reporting their scores, that 50% of them were carrying around a terrible burden of fatigue. So they were in that moderate to severe range with fatigue, that their appetites were impaired, their well-being was impaired, that they were feeling pain. 40% of the population was living with moderate to severe pain, okay? So all of these things were showing us in these early stages of like actually documenting what people were experiencing with their cancer, that the quality of life, if you ask about it, is pretty poor and not being managed very well for folks who are not even near the end of life, okay? And so as I sort of grew up in medicine, I thought to myself, you know, it's important not just to fix the cancer or treat the cancer with chemo, disease-directed treatment. It's also really important to figure out how we can get the quality of life or the world of the patient in better control. Because I know I have the data that says now that most of my patients are carrying around this backpack of symptoms that's not getting any better. And I'll tell you that this was from, you know, this data was collected over like 20 years ago, you know, thinking about when all of these tools were being collected so that we could get it to a time where we could even publish it, I think in 2013. So this is old data, right? Think about even now with the more treatments that people get. They live longer, they get more treatments. So this might even be worse. So what do we do about this, right? As a group of people, what can we do? So my messaging for you today, and somebody asked, what's palliative care? Well, we're going to learn about it, because what can we do about this burden of symptoms, and how can we optimize and thrive our quality of life with cancer is to get palliative care. It's what every woman needs to know about. And I've interviewed patients, and I'm going to just put their little excerpts of interviews in this to help us sort of learn more about it, okay? So Petra is one of my patients, and I asked Petra, how would you describe palliative care to another patient after she'd been in our sessions for a while? So before I received palliative care, I had the wrong idea about it. I thought it was hospice, end of life care, and that made me afraid. There needs to be more education about what palliative care is. It's not something you have to be afraid of. You have to have a serious illness, but the earlier you do it, the better. You know, what Petra is saying is actually not uncommon. A lot of people think that palliative care is Dr. Death. Oh my God, they are sending me to a palliative care doctor because they think that I'm dying with my illness. I will tell you that the reason this probably happened, okay, was that the origin of palliative care and the science of palliative care came out of the modern hospice movement. And so we know that that's where that preliminary stigma came from. But what I'm here to tell you is that palliative care has moved way up front. In fact, the only qualification you need to have for getting palliative care is having a serious illness and then having some distress that needs to be managed by a doctor who's a specialist in managing the symptoms and stress of cancer. So we're going to talk a little bit about it. This is the contemporary definition of palliative care. And it was come up with after interviewing patients and caregivers about what palliative care really was for them through their experience. So palliative care, also known as palliative medicine, is specialized medical care for people living with serious illness. And I want to just like put that out there. We're living with serious illness. It focuses on providing relief from the symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family, because when we go through serious illness, we do not do it alone. Palliative care is provided by a team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. Okay, in our case, we're talking about on top of your cancer-directed care. It's appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. Okay, so we're really flipping that old idea of what palliative care is on its head. Okay, so we also know, and this is coming from a huge amount of studies. Okay, this is evidence-based information I'm giving you here, just like when they're talking to you about getting a pill for your treatment or a new chemo, that the reason they're recommending it to you is it's evidence-based. It's found in research that exposure to palliative care, having a visit with a doctor who does palliative care, reduces your symptom burden. It improves the quality of life of patients during treatment. It improves the quality of end-of-life care. People live longer and many times have a longer time on hospice, more time with their family, and better quality of life in the dying phase of their illness. It improves caregiver well-being, because we know that your caregivers are stressed out. It improves patient satisfaction with care. Overall, folks understand their care better and feel better about it because they feel more in control of it when they're working with a palliative care doctor. And this is the really important thing that a lot of people don't really know about, that actually palliative care consultation has been shown in many, many studies to improve survival for patients. That is the only intervention in these studies between groups, and people live longer. And I'm going to argue that it's probably because folks choose less treatment as they're nearing the end of their life and actually end up living longer because of that. So the treatment changes from thinking about chemotherapy to working on symptoms and their function in their quality of life. So we don't have a study that says that, but I'm going to guess that that's what it is, because in all those studies, we see that the folks who lived longer chose less drugs, less chemo, less radiation, less interventions, and ended up living longer. So I'm going to guess that that's what it's about. So if we can manage your symptoms, then even at the end of life, you can live longer. So another patient, Dorothy, how would you describe palliative care to another patient? They seem to be experts in quality of life and managing symptoms. It doesn't matter if you're currently in treatment or not in treatment. And it doesn't have to be at the end of life, although it could be. So palliative care assessments and what we call an extra layer of support go along with the cancer-directed care. I like to think about it with this diagram. So at the center of your world of treatment is your cancer-directed therapy. And then my job in palliative care is to explore all of these other areas of treatment. And so what do those look like? Your physical function. Debility means how much is this cancer or the treatments affecting your ability to bathe yourself, dress yourself, walk around, be mobile. Emotional health, spiritual health. We explore prognostication, meaning foretelling time. So prognostication means that I work with folks to say, I'm worried that you're entering a different time in your illness and that time is getting shorter. I can see that in how they're changing over time. In palliative care, we work on values clarification and cancer coping, and I'm going to sort of like get into that a little bit more on a later slide. We work on symptom management. We care about caregivers. We invite them to our visits and make sure that they're getting the support that they need also. We care about your social health. So what does all that look like? Basically, the package of palliative care is that we are assessing everything around your cancer-directed therapy and figuring out ways that we can help you thrive while you're going through treatment, okay? So something that's really important is to think about what else can I do to improve my quality of life beyond the palliative care visit. And I'll just say, these are common referrals that I make if I detect that there's distress in different areas that I was assessing. So psycho-oncology or oncopsychology, they call it different things at different institutions, but many cancer centers now have devoted psychology teams that specifically work on therapy for folks who are going through cancer therapy. It sounds like someone is off of mute, and I hear like keys or a car or something like that. I'm not sure. So I would just ask you to just look at your screen and just check that out. And I'll also point out that usually psycho-oncology is usually covered by insurance. The other thing that I really recommend to folks going through cancer therapy is physical therapy. And the reason is that, especially if you are sort of age greater than 65, you're really susceptible to losing your physical strength and function as you're going through treatment. Many people think physical therapy has to be about fixing a broken bone or somebody had a stroke. But actually, we are using physical therapy now to rehabilitate or maintain physical resilience throughout cancer care. Physical therapy also treats a lot of symptoms. And so neuropathy came up as a main symptom that people were texting about in the chat box. Physical therapy is one of the best ways to treat neuropathy, because they can give you exercises to move around your hands and feet. It's also usually covered by insurance. Acupuncture is not covered by most insurance, but it definitely has been shown to have multitude of different symptom benefits and overall wellness relaxation benefits. But the symptoms specifically that it can help with are pain, nausea, fatigue. Again, because it is an intervention, it doesn't last long term. Usually it lasts for a couple of days of effect, and you need to go back again on sort of a weekly basis to get acupuncture. And then sometimes you stabilize a symptom, and then you can space out the visits. But it is definitely something that you can use. And many acupuncturists who treat folks who have cancer are also sensitive to the fact that sometimes your platelets are a little bit off and you can't get needles. And they do things like acupressure or lasering, like what is it called? Cold laser therapy, things like that. So they have alternatives. Oh, I love this stuff that's coming up in the chat right now. Acupuncture, Tai Chi has helped a lot. There's actually studies that show Tai Chi can help with insomnia and fatigue. Moving your body with yoga, all of these things can help manage those symptoms, and getting your body in motion. Just in general, these are things that we emphasize over and over again and love in palliative care. Massage, also treat yourself. If you have the resources, it is the time when you're going through treatment to give yourself the gift of massage and caregiving, that folks care for your body in all these different ways. The other thing are support groups. So everyone in OCRA has the opportunity to participate in different programs like the woman-to-woman program, but also in your local cancer centers. Like we have a program called Turning Point through KU that has support groups, it has nutrition, it has a lot of different resources for folks walking through the cancer care journey. Somebody mentioned mindfulness before, Tai Chi, and most towns have these types of support centers in them. You just sort of have to reach out and find them. One that's common also is Gilda's Club, because Gilda Radner, she passed from ovarian cancer, and part of her legacy was to create a place of support for people going through different types of cancer. And so these are all of the other things that we can do to work on our health while we're walking through the cancer journey. So Dorothy, what do we do in our visits together? What's the nitty gritty of like what we actually do in palliative care? So Dr. Spoozak and her team talks to me about quality of life. That's her number one concern. They want to make sure I'm not in pain. I eat, I sleep, I have energy. And then we talk about what's best for me. We discuss the pros and cons of treatments and clinical trials. So something that we do in palliative care also, or like I've really pivoted to a lot, is that it used to be that people referred us folks who were in a lot of distress, and then they were late referrals to palliative care where people were closer to the end of life. But as people are learning more about palliative care, living longer, a lot of our visits have turned into, we work together for years and years and years. Some people even graduate from palliative care, if you can imagine that, and like flip that whole notion of what palliative care used to be on its head. And so now what I've realized is that in our visits, after we put out the fires of like a crisis for symptom management or whatever is going on that's a crisis, then we get the luxury of starting to talk about how do we maintain and live to the best that we can with the body that we have right now and the life that we have right now. So things that I like to emphasize are goal setting and future planning. I think about my job now for a lot of folks as life coaching, reminding folks like, now that we have a body, now that we have the ability to use our body well, how are we going to do that? And not everyone is the same. Some people still are wheelchair users. Some people are using walkers. But in this body right now, what can I still do? And so we really challenge folks in our visits to name those things and to set up a plan for themselves. This form, actually, after all of our conversations, was created by one of my patients and their family to like keep their mom accountable for each day tracking what she's doing with her time. On another side, it was about physical therapy and stuff like that too. But what are your short-term goals? 1 day, 1 week? What are your long-term goals? 1 month, 1 year? We really want to not let cancer take away from us the ability to future plan. Even though cancer brings death and dying closer into our view, we still need to learn how to then step away from that and be able to still think about and plan for our future. Whatever that time scale may be that you feel comfortable planning for, it's really important for thriving and living in this moment right now in your body and living well to be able to still do future planning. So this is a big part of the activities that I do in my palliative care visits. Okay. Another thing that comes up a lot as we're walking this cancer journey, in remission, cancer comes back, in remission, cancer comes back, cancer might be with me now, and it's stable, and it's stable, and it's stable, and then a scan comes, and then it's a little bit bigger, and then it's stable again. So it's really scary to cope with cancer, right? It's like a lot on our plate. And a lot of people talk about scanxiety, where I get nervous before my 3-month visits with my provider, or every 3 cycles I'm going to see my doctor. So it is, most people with serious illness swing back and forth between times when they're more worried and times when they're more hopeful. That is normal. Being worried and hopeful is a healthy and natural part of coping. And talking about your coping helps loved ones know how to best support you. And it also helps your doctors. And so a lot of the things that we do is talk about healthy coping with cancer in our palliative care visits as well. So again, Petra is one of my patients. Has this helped you with your cancer? Absolutely. She helps with the stuff the oncologist doesn't have time to deal with: anxiety, sleep disturbance, pain management. It's nice to know another doctor. I have another doctor to talk to. When I first met her, I was a mess psychologically. I feel 10 times better than I felt before I saw her. What's the greatest way palliative care has impacted your life? That's stress and anxiety management. The stress that comes with having this illness, anxiety is harmful, and she helped me manage that. So what do we do to help people control anxiety? Because you can't think your way out of anxiety. So By the way, all of these resources, I just want to call out MGA Continuum Project, MGH, Mass General Continuum Project resources for talking with your loved ones. They have PDFs that you can download, and also they have a website where you can scroll through things. They have two different things that are really important. One is talking to your loved ones about what's important to you, and also healthy coping strategies. And this is where this card sort of came from. The other thing is how to talk to your physicians about what's most important to you, because that's really important to know what your boundaries are, what your goals are, and to help do what we're really aiming for right now in life, which is called goal concordant care, meaning I'm going to only offer you treatments that align with what your goals are. Sometimes, for example, I'm going to put my GYN oncology hat on in my clinic. Okay, you're thriving, you're doing well. Your goal is living longer and living well. Okay, great. I think you are still fit for more cancer-directed therapy, like chemotherapy. Okay, we're going along. At some point, something changes. Your function is very poor. You're not able to spend more than half of the day out of the bed. You're not eating. You feel very unwell. You're even seeing palliative care, and all the work they're doing with you is not able to change it. Well, something has changed. And so now that same goal of living longer, well, the treatment that I'm going to give you is going to be different. Guess what? It's not going to be more chemo. It's going to be, I'm going to work on exclusively managing your symptoms and getting the supports you need to you at home. And so these are why it's really important to know what your goals are and to be able to express that to your family, because the same treatment that was the thing that we did before to help you with your goals may not be the same thing later on in your cancer journey. So I hope I'm sort of being clear about that, but we can talk a little bit more about that in the next slide. But part of coping with cancer has to do with articulating what you want and need. So other things for coping strategies that we really walk through are all of these tools on here, and reminding people as you're approaching your treatment visit, where it's that 3-month visit where you're like, uh-oh, am I going to stay on treatment? Am I not? I'm really worried. I don't know what my scans are going to be. So I really pump up the coping skills and remind folks, okay, it's okay to do distraction things, hobbies, puzzles, game, working, problem solving. So making plans, seeking social support. Who are the friends you're going to call in this week leading up to your scans? Okay. Mind body strategies. So I put some names of free apps over here. The Virtual Hope Box is an app that the VA made, and it's a coping app. It's actually made for folks, I think, who had like PTSD and unmanaged anxiety. But I use it a lot because it's a free tool, and it has breathing exercises, it has meditations. And the reason that these things are really important, so mind body strategies of relaxation techniques, good sleep and exercise when possible, pacing activities to conserve energy. Why are these things important for managing your anxiety? Well, you can't think your way out of anxiety. Anxiety is like this spiral, and your brain will just go in this spiral loop. So the only way you can get out of it is through the body. So if you can't go for a run because your function is not there, maybe you can do some chair yoga. If you can't do chair yoga, for sure you're breathing. So you can do breathing exercises. So we walk through what you can do in your body right now to help manage that energy that comes up, because anxiety is basically a manifestation of some emotion that's not being expressed well or coped with well. Usually it's fear, and maybe it's anger, and we talk to you about some techniques that you can use in your body right now to manage those emotions that are not being managed, and get rid of that excess energy. And we can tailor that to whatever you're dealing with in your body at the moment, okay? It doesn't just have to be the same old tool you used to use when your body was working better. Oh, I used to play tennis. Well, now I'm not able to play tennis. So we have to pivot and find something else that works to get rid of that energy. religious and spiritual activities. So something that I've noticed in cancer care and in palliative care is that folks are typically have a spiritual practice of some sort. But many times when folks have cancer, instead of moving towards their spiritual practice and their faith group and community, a lot of people retreat. And it can be multifold, but sometimes it's about having the energy to go to church. COVID really did a number on our ability to participate in temple or whatever, whatever prayer group or spiritual faith background you're a part of. And so finding ways to be creative to get access to those groups. Yes, we can have a personal practice of prayer, whatever that looks like, again, for you. However, the community that connects us through having a spiritual or a faith community is really, really important when you're walking through your cancer journey. And so being creative with and accepting help in others and sharing what you're going through with your faith community is super important as a way to cope with all of the pressures that cancer puts on you. Journaling and reflecting on life experiences is very, very meaningful for folks, especially the more physically limited you are. The things that you can retain are your ability to tell stories and also your ability to breathe. And so it's really, really important to share stories. There's a whole strategy of tools that people made called dignity therapy, and they're questions that were created to create a journal sort of it was made for the end of life, but I've actually moved it up and used it for all of my patients at any time. And also I've started doing it with my own family. It's questions like talking to your family about what you're most proud of. So now whenever we have a big dinner, say it's like a Christmas dinner or something like that, I will go around and ask one of these questions. And no matter what your age is, everyone answers one of these important questions and shares, because we think we know our family, we think we know the people we love, but we're always surprised at what we learn when we ask these really lovely, important questions, and it makes us more connected. And then reframing your cancer in a helpful way. So thinking about actually, sometimes illness actually brings good things. It brings relationships closer. It brings us connections that we wouldn't have otherwise had. And so positive reframing can also be very helpful. So I think I went through all of this stuff. And then I guess at the end of the day, if all of these actions aren't able to help, I also talk about medication, because sometimes a symptom is so overwhelming that we actually have to use medication in order to tame it. And that's okay. Okay. So this is something that's really, really critical. And it's another thing that we facilitate in palliative care for patients and their families. It's talking about what matters most. Okay. I can't tell you how often I hear, oh, well, they know what I want, or they, when they is your caregiver or your family, oh, they'll be able to do the right thing for me when I want it. And then if you bring a family member into the room, they're like, well, I don't know what you want and need, right? So we assume that our family knows what we're hoping for and what we're worried about and what's most important to us. But the truth is that unless you share, most people don't know and have assumptions that a lot of times are not true. Okay. And so it's really, really important to share these things with each other. A lot of our families are guarded. They don't want to share because they think it's going to injure another family member to share. What I would offer to you as a strategy is to say, hey, I'd really like to talk about this. Do I have your permission to share about my hopes, my worries, and what's important to me? Is it okay? Because it's really important to me. It would make me feel a lot better to be able to do that. I would argue that probably 95% of the time, there's going to be 5% of outliers that don't want to hear it, but 95% of the time, your family does want to know. So I hope in the days ahead, I'll continue to feel well for a long time, get stronger. At the start of this, when we were talking about thriving with cancer, what does thriving look like? For some folks, it was living well, quality of life. Time is less important. Some people, time is more important. What am I worried about in the days ahead? I'm worried about getting weaker or being a burden. How can we talk about that openly and figure out ways of bird dogging that before it becomes a problem and everyone's stressed out? I'm worried that time is shorter than we hope for. How do we face that together as a family or a caregiver unit? And then what's most important? I'd like to share what's most important to me if my health were to worsen. So, for example, if I'm getting so sick where chemotherapy is no longer going to lengthen my life, what is important to you if time's getting shorter? Spending time with my family, for example, maintaining independence, living as long as possible, fighting the illness, dying a natural death. My screen is being blocked by the chat, but not be a burden, be mentally aware. I would just ask you all, like, to the group, are these things that you have talked about with your family? Do you tell them these things? Is this a comment? Like, I just want to take the temperature of the room. How often do we talk about what's most important to us when we're really talking about the big picture? I'm shouting that out as a question. How often are folks talking about it? It changes when I share. So, like, for some people, maybe you share more, maybe you share less. Not often. Okay. Not often. Okay. And I think that that's pretty common. A lot of folks. I actually love that comment. Women in general find it difficult to share self-concerns. And I would agree with that actually societally we've been coached not to complain, not to say what we want and need. So this is actually the 5% here that I'm looking at. What if your family is in denial and doesn't want to talk about it? A lot of times what we're conditioned to do as women is not share, not talk. And also our family might impose on us that they don't want to hear about it. They don't want to talk about it. One strategy is that I will often invite a family to come into, for example, my palliative care visit or my GYN oncology visit and ask them permission to be the one to share the news. And then to also invite that it needs to be grounded in that this will help you feel better and unburdened. That Dorothy will feel better if she can share with you what's most important to her. And if what's most important to Dorothy is not in line with what's most important to the family, then we can talk through that together in palliative care. And it's actually a really important another reason for palliative care consultation. Just looking through the rest of this. It also depends who I share with. I share with my husband and close friends. I told to hold back on my dad, not to worry him so much. It's hard to talk about disease winning. I also would whenever we use the language of winning and losing, I just want to call that out, that everyone is working so hard when they're on the cancer care journey. I will argue that you are always doing the work. You are always winning. If cancer progresses, it's not about winning or losing. It's something that's not in your control. And I would want to reframe that for all of my folks, that you are winning by showing up to care. You are winning by being present in your body. You're winning by breathing another day. And I wish that we could control the cancer. That's not something that usually we try our best to treat it, but sometimes cancer is not something we can control. So we're going to optimize everything else around that. And certainly no one is losing when they're walking through the cancer care journey, because everyone is working so hard. Many times I even encourage folks on those visits between treatments where you're about to have a life-changing visit. It might be life-changing because I might be progressing. I might be staying the same. The cancer might be cured. The cancer might have come back. Is that you give yourself credit no matter what happens on that day by making a date for dinner, making a celebration, honoring yourself, giving yourself a massage for all of the work you have done to care for yourself, all of the things your doctor has asked of you to do that you have done, and celebrate yourselves because of the work that you're doing. Yeah. I'm looking at that. I cringe when someone says she lost her battle with cancer. I hate to hear that. I agree. This is not a battleship. We're not on a cruiser here. This is your life, and you're doing the best you can in the body that you have right now. And your family is doing the best they can do with all of the resources and love and support, and your community is doing the best they can do. It's certainly not a war that we're fighting here. It is a journey of compassion, and all of the members of that team of care are doing the absolute best that they can do. Someone here, I was lucky to be openly talked about what was important to all of us, to be able to openly talk about what was important to all of us. That is such a gift. The other thing that we know about when people are walking through the cancer care journey, the better that they can be with alignment with the care team that they have, meaning their caregivers, and what the patient wants, the better they will do if the patient passes away from a serious illness. And so the more open communication channels that we can facilitate so that everyone's on the same page, the better everyone will do while a person is alive and after. Yeah. I'm going to just flip. So Dorothy, when we're talking about palliative care, has this changed your relationships? If so, how? Yes, it's helped my family relationships. Dr. Spoozak's able to calm my fears, then I'm able to pass that information and feeling on to my children. It helped them understand and get in place where they can accept what's happening. I could turn around and use her words to talk to my children, and I think this has helped them treat me differently. They respect my wishes and understand that I'm not doing something wrong. So who can have a consult with palliative care? Anyone with a serious illness if they're in distress. Palliative care is not just for cancer care. Palliative care is for anyone, heart failure, someone who's on dialysis, who's not a candidate for transplant and not thriving, someone with severe dementia. And how palliative care is delivered is different in different places, but most major cancer centers, certainly NCI designated cancer centers, have both inpatient and outpatient palliative care. If you have moderate to severe symptoms, if you have stage 3 or 4 cancer at any time in treatment, if you're struggling, and even if it's curative intent, recurrent ovarian cancer, that's platinum resistant especially, if you're having a plan for a complex pelvic surgery like pelvic exenteration, where all of your GYN organs and your bladder and your colon are removed, that's a great place for a palliative care visit to help you go through that journey. Trouble coping with cancer or fear of death. A lot of folks can't shake this. Even if they're cured of their cancer, they're really struggling with coping with the cancer and fear of death. And so palliative care has a place that can help you with that. If you're having multiple hospitalizations, if you're wanting a deeper discussion of things like advanced directives, thinking again about what's most important to me, like emergency health orders, these are reasons for palliative care consultation. Palliative care is a medical care like all other care, and you may request it and request a consult, just like you may request a consultation to see a primary care doctor. So in your hospital system, if you have outpatient palliative care, know that it's something that you have the right to request a visit to. Okay, so that's my last message. Get palliative care and celebrate life, okay? We want people to live longer and better. I really can't say that enough. And it's been my pleasure to talk to you all. Um, and we have like 10 minutes left for more questions. If you want to engage in more discussion about the things that came up through our talk today. Thank you. All right. Well, thank you. Oh, what's the name of the journal you suggested? I'm not sure if you're talking to me about that, but dignity therapy is where, if you Google dignity therapy, it has questions about sort of your life and reflecting on your life. And those are things that you can use as a tool at any time in your life with your family to document and to think through ways of knowing each other and our legacy in a more meaningful way. So I'm not sure if that's the journal. The other thing that I put up, and I could maybe flip back to, is just the Mass General, the Continuum Project, resources, talking with your loved ones. That's another thing that I posted that is really important, and it's a great website. If our cancer center doesn't have palliative care, how can we be part of it? So number one, ask your doctors and your cancer center for palliative care. That's my first plug as a palliative care doctor. Number two, it depends on sort of like what you do have. So if you don't have outpatient palliative care, maybe you have oncopsychology, or you can get access to therapy in your community. Maybe you have pain management. Maybe you have physical therapy. So thinking about all the things that we talked about, what are ways you can access tools to make you live better and feel better, even if it's not through an outpatient palliative care visit? When I asked about palliative care, my doctor said he will provide, but not. What can I do? You are allowed to ask for a palliative care consultation, regardless of what your doctor says. Many doctors believe still, because again, where did palliative care get born? It got born in that hospice movement. A lot of doctors who are older doctors believe palliative care is still for the end of life. And so a lot of them don't know, and you have to educate them. Just like a lot of patients have to educate their doctors about new drugs. That's why you're at this conference, right? Is to learn about the current things. That's why you are part of support groups. It's not just to talk about coping, but also you're learning about new important things. And so a lot of times patients are doing as much educating as doctors are doing. And so give yourself credit for that, and know that if this is something that's good for me, I'm going to seek it out and demand it for myself regardless. The other thing is, sometimes a doctor says, oh, you're too well for palliative care. Well, have a visit, and then the palliative care doctor can say, let's do a check-in in 3 months. Let's say I'm here for you. We have one visit. You're doing well. Maybe this is not the time, but you know who I am and where I am. And you can set it up as an as-needed follow-up. So there's no right way of doing it, but if it's there at your cancer center, then you can absolutely demand a consultation. All right. How do we know when to switch to hospice care? Ooh, I gave a lecture about this last year, and I wonder if the slides are still available. That's really kind. Thank you, Maria. But when do we switch to hospice care? So the long and short of it is that your ability to tolerate more treatment and the proximity, the closeness to the end of life has to do with your function, number one. So when people are spending more than half of the day in the bed or chair, when your appetite and energy are seriously depleted, we know, actually, and this is symptom scale I'm putting up here, actually reflects this. When these symptoms of tiredness, poor appetite, and fatigue start climbing, drowsiness start climbing, this is when we know that we're in the end of life. Usually the last 3 months of life is when these symptoms get out of control. It's usually not pain, it's not other things. So this is what we see. And so when we start seeing these changes, and that's reflected by spending all this time in bed or chair, not being interested in food, all of this stuff, giving you more treatment with chemotherapy is very harmful and actually can shorten your life. And so it's actually the most important time to think about a transition to a hospice plan of care. So, for example, I still see a lot of patients who are not taking disease-directed treatment, but are not ready yet for a hospice plan of care because I can't prognosticate for them. They're way out here. They don't have a lot of symptoms. They're living their life. They're doing well, but they've just chosen, I don't want any more chemo. Fine. So in my palliative care visits, I see them until I start seeing these changes in their bodies. And I don't need a CAT scan to see that someone's entering the dying phase of their illness. It is not usually correlated to how big your cancer is or where it is in your body. It has to do with your function more than anything else that we have ever seen. So I don't know if that's helpful or reassuring, but what I tell people is as long as you're thriving, you're living well, you're dressing yourself, you're bathing yourself, you're doing your regular routine, then you're probably doing very well. And I cannot actually give you a clear prognosis or how much time you have left with your disease. So I hope that that's helpful and answers that question. All right. And it looks like Tracy said that the session from last year might be available. It says, you reference your team. What happens if you receive palliative care from one site and have a team of physicians at another site and a oncologist at another? Do palliative care team members gather everyone for the betterment of the patient? So it is very difficult to provide care across healthcare systems because you don't have access to records very easily. So that's a very tricky thing to do. Many times we ask people to be getting care within our healthcare system, or at least have some touch points. And I think that last question, it says, how do I know I'm in my last few months or days? That's exactly what I was talking about with how your symptoms are doing and how's your function doing. So as your symptoms get very severe for tiredness, appetite gets very bad, your function gets very bad, that's when we know that you're entering the last few months of life. All right. Thank you, Tracy. You're going to look on the last year's video. That's good. I think I got through most of the questions here at the end. Okay. All right. Well, it's been a pleasure to talk to everyone. I can't say enough about how much I love OCRA and how much they've done for our community and our patients. And whenever they need me to talk, I'm happy to talk and do whatever I can to support the organization and our patients out there. I love working with you all. So